Good afternoon. I would like to thank the organizing committee for making this conference possible in the UK. And I will talk about CCSBI and concentrate on the angiographic findings of CCSBI. As all of you know, CCSBI is a syndrome seen in multiple sclerosis patients characterized by multiple areas of stenosis involving the internal jugular vein and the azygos vein, which are the main draining channels of the brain and spinal cord. This results in two things: opening of collaterals to overcome cerebrospinal venous hypertension, and insufficient drainage of the brain and the spinal cord. The diagnosis of CCSBI is mainly by Doppler ultrasound. However, Doppler needs special training and it is operator dependent. The gold standard is catheter angiography. MRV is an optional. However, I think in the near future, functional MRV or MRI will replace Doppler ultrasound for diagnosis of CCSBI. These are the main Doppler criteria for diagnosis of CCSBI. We have reflux in the internal jugular vein, reflux in the cortical veins, evidence of stenosis, no flow at all in the jugular vein, and negative change in the cross-sectional area of the internal jugular vein. The prevalence of CCSBI in MS patients is very high, ranging from 80 to 100%. And these are the distribution of venous stenosis in CCSBI. The most common site for stenosis is, of course, the left internal jugular vein. This is the most common site for stenosis, which I believe because of the complex anatomy and the embryology in this region. So it's much common than the right internal jugular vein and the azygos vein. Now I'll show you the angiographic findings of CCSBI. This is the most common angiographic finding, tight stenosis of the internal jugular vein at the level of the valve. This is very common finding on catheter angiography, although it's very difficult to see on Doppler ultrasound, because this area of stenosis is usually behind the clavicle and hidden by the clavicle and the bony structures, so it's difficult to see on ultrasound and very easily demonstrated on venography. This is corresponding to criteria number 3 by Doppler ultrasound, which is evidence of stenosis. Again, another common sign on angiogram is very tight narrowing of the internal jugular vein. So the internal jugular vein, and here the area of the valve, you see very tight narrowing, some collateral formation. This is what I call the jugular atalasia sign. Aneurysmal dilatation of the jugular vein and severe tight narrowing at the valve. Again, stagnation of the contrast within the internal jugular vein is a common finding on angiography, and it is equivalent to criteria number 4, which is flow not detectable on Doppler by sonography. So you can see the contrast holding up in the internal jugular vein, and there is no drainage into the superior vena cava of the heart. And you can see the large collateral draining the right side of the brain. Again, another common finding, tight stenosis at the valve, large collateral formation. Again, it's not a very clear picture, but you can appreciate some dilatation of the jugular vein here, and you can see the drainage is very, very sluggish. It's like dribbling of the blood from the jugular into the heart. Not complete obstruction, but very, very severe narrowing and sluggish flow. Sometimes we see malformation of the valve, like in this case, you can see septum inside the vein. It is malformed above, causing severe narrowing, and you see the contrast. The dye is not going from the jugular vein down. It's very slow. Again, we have seen like this in just in a few cases, flap or filling defect, what we call filling defect inside the lumen of the vein, causing stagnation of the contrast in the jugular vein. This is intraluminal flap. Reflux is very common finding on venography. In this case, you can on the left-hand side, you can see the reflux in the internal jugular vein, which is criteria number 1 by Doppler ultrasound. And in few cases, you can see the reflux is going back into the brain and refluxing into the other jugular vein. So this is equivalent to criteria number 2, which is reflux propagated upward. Again, this is a very interesting case. This is the left internal jugular vein here, and this is the right internal jugular vein. There was complete reversal of flow in the left internal jugular vein. So the flow in the left internal jugular vein was completely toward the brain. It's like injecting the contrast or the dye in the carotid artery. There was no flow down at all. Even at very low injection pressure, all the contrast is going back up into the brain and refluxing into the right jugular vein. You can see here the contrast is faint. In this case, we did measure the pressure gradient between the right and the left internal jugular vein. This is the left internal jugular vein. You can see a very high pressure, and the flow is forward. The pressure is 11 millimeter, and in the right side, the pressure is 3 millimeters. So there's a big difference. And the blood is going from the high pressure to low pressure. So all the contrast going from the left jugular vein upward to the brain and down into the right jugular vein. We have seen this in a few cases. Again, a typical finding, severe stenosis of the internal jugular vein. In this case, it's upward at the base of the skull at the C1, C2 level, and a huge collateral formation. In some cases, we can see a complete occlusion of the jugular vein, but this was a secondary occlusion due to central line insertion of the right internal jugular vein. There was no jugular vein on the right side. All the contrast is going through collaterals and filling the left internal jugular vein, which also has tight narrowing seen here during balloon angioplasty. You see tight narrowing of the left internal jugular vein.